All right, welcome. My name is Vic Anand. I'm a pediatric infectious disease doctor practicing in Los Angeles, and we'll be talking about antibiotics. So I'll divide this talk into a whole bunch. Usually I do this talk interactively, so we'll see how this goes, but it's just kind of here as a quick reference to go over the various antibiotics. I think I've seen a lot of different techniques and a lot of little shortcuts, but the problem is at some point, antibiotics really do have their own little nuances, and you kind of have to know them. And if you don't, bad things can happen, and you end up making a mistake. So let us start with the introduction. The way I kind of like to think about antibiotics is how do I kill these things that are trying to kill my patients? And we'll start by reviewing the central dogma of cell biology. And that is DNA goes to RNA, and this goes to proteins. And what do proteins do? Well, they do lots of stuff. So, not the most thorough review of cell biology, but that's fine. And all of this is wrapped in a cell membrane, like so. A lot of people kind of want to say the nucleus, but remember these are prokaryotes, so pro before carrion kernel, so before the nucleus, and eukaryotes, of course, do in fact have a nucleus. So all of this is wrapped in a cell membrane, and the way we kind of divide up bacteria is based on being gram positive or gram negative. So let's see here. Let's pick a gram positive color, which is a nice purple. So let me pan a little bit here. One sec. So let's make some space. And we have gram positives, and we have gram negatives. And what's the distinction between a gram positive and gram negative? A lot of people say cell wall, right? But actually, both gram positives and gram negatives have cell walls made out of peptidoglycans, and they stain purple with crystal violet, which is how it gets its name. This is the peptidoglycan cell wall. But gram negatives also have one. It tends to be a little bit thinner, in fact, quite a bit thinner. But what's most important about the gram negatives and why they don't stain is that they have another layer. They have an outer membrane. And that outer membrane is made up of phospholipids just like this one, but it also has an important molecule called lipopolysaccharide, which is also known as endotoxin. And that endotoxin is responsible for a lot of the inflammatory reaction we see. And we'll talk a little bit about that as we go. But the only way through this is through a molecule called an outer membrane pore. And that is why there's generally a big distinction between antibiotics that work on gram positives versus antibiotics that work on gram negatives, is really you have to be able to get through that outer membrane pore if you're gonna be able to act either on stuff intracellularly or even get at this the cell wall in the intermembrane space. All right, so what are some gram positives? And I think most people will just yell out staph and strep. But after this lecture, you are no longer allowed to just say staph and strep. You really have to know which staph and strep. And so staph, we generally divide into two big categories, Staph aureus and all the other staphs, and usually referred to as coag-negative staphs. And the way we divide up Staph aureus is typically MSSA and MRSA for methicillin susceptible and methicillin resistant Staph aureus. Then we have our streps. And there's a whole lot of streps, but the ones that we're most interested in are group A strep, which is the classic, causes strep throat, causes erysipelas, cellulitis. We certainly in pediatrics have to worry about group B strep, its cousin. There's also group G, group G strep and group C strep. Probably should have done that in alphabetical order, but whatever. Both of those can cause pharyngitis, although not usually as pathogenic as group A strep is. All right, and then you got a tooth infection or a gum infection. What do you have? Or even a sinus infection. We have to worry about the viridins group streps, like strep mitis, strep oralis, strep intermedius, all those guys. And then the big other pathogenic strep that we need to think about is, of course, pneumococcus, strep pneumo. Pneumococcus. There's also like strep bovis and a number of others, but those are the sort of the big categories that we need to think about. And then the other last one that we need to think about is a cousin of strep. I usually ask people, you've got a person who's had a catheter in, and now they have fever and pain when they urinate or just in their bladder or flank pain. What do they have? They have a UTI, and let's say on the gram stain of the bacteria, it's gram positive. What is it? And the answer is the enterococci. These actually used to be known as group D strep, but got reclassified. And the two big ones, there's actually quite a number of strain of enterococci, but the two clinically relevant, most commonly encountered are fecalis and faecium. Easily named so that there's no confusion. But again, similar to SSA and MRSA, which one would you prefer to get? You generally prefer to get fecalis. Faecium tends to be the more resistant one, so I'll put a little asterisk by the more troublesome ones. I guess pneumococcus also gets a distinction of being a little bit more troublesome than the others. All right, which then leaves us with gram negatives, right? That's it. That's all we have to know. So in terms of gram negatives, what do we have to know? The big ones. What is the most common gram negative infection that anyone's going to get? It's a UTI, and it's caused by good old E. coli. And if it's not E. coli causing a UTI, it'll be Klebsiella. And if it's not Klebsiella, it's Proteus. And sure, there's others, like, for instance, Staph saprophyticus comes in there. But these are the big three sort of UTI bugs. And in this group, we call these the Enterobacteriales, formerly known as Enterobacteriaceae, but now Enterobacteriales. Microbiologists just love changing the names of all these things we get used to. That needs to stop. So if you're a microbiologist out there, grumble at you. But we certainly have another bacteria we need to think about in the Enterobacteriales group, and that's Enterobacter. And Citrobacter is in there too. Something I always like to ask people, if you decide you're going to be an adventurous eater in an underdeveloped nation, there's another group of bacteria we need to think about. Sudden high fever, you're traveling, sudden high fever, really bad abdominal pain, constipation over diarrhea initially anyways. And then eventually, if it's untreated and you're one of the unlucky few, splenic rupture or intestinal rupture. And that is salmonella. And the way we divide up salmonella is the one that this poor person got, being an adventurous eater, which is typhoidal salmonella. And of course, we have the conventional salmonella and non-typhoidal salmonella, which is usually the cause of fever, mucousy diarrhea, and generally only a problem with the immunocompromised. The vast majority of other people will just have, or very young of age, but the majority of people will just have a self-limited diarrhea. And let's say you're an adventurous eater, and this time around you have high fevers, shaking chills, bloody diarrhea, and seizures, then that would be classically Shigella, which is another one. In fact, Shigella is so similar to E. coli that actually some of our molecular testing has trouble distinguishing the two. So the MALDI-TOF, which we now use to really distinguish clinically strains from each other, has trouble with Shigella. This is so similar to E. coli. And we sort of lump these in as the enteric gram negatives, And we still have a bunch of other gram negatives to talk about. Um, and big scourge of the ICU also can cause osteo if you step on a nail, or folliculitis if you enjoy a hot tub. You guessed it, it's green, it's Pseudomonas. Another scourge of the ICU, we'll just go back to red, that becomes very drug resistant is Acinetobacter. I have a nice red pen, so you can guess another environmental gram negative, and that's Serratia. And another common issue with like ET tubes, ventilator associated tracheitis, pneumonias is Stenotrophomonas. Now, again, there's a lot of other bacteria, but these are the ones you'll sort of clinically run into a lot, and that's why we'll talk about them. And these are our environmental gram negatives. And then we have one last group of gram negatives. Question I always like to ask people: you've got a kid with ear pain, a runny nose, cough. What do they likely have? And you look in their ear, and it's kind of the drum's a little bit red. What do they likely have? And you'll end up getting a lot of strep pneumo and a few other bacteria that we'll talk about, but the reality is it's a virus. Don't forget that. But if you don't have strep pneumo and you don't have a virus, or you did have a virus and now you have an acute otitis media, what is one of those? It's H flu. And H flu does encompass Hib, which we certainly worry about quite a bit, causing serious invasive infections. Fortunately, at least for now, vaccines have generally done away with Hib. But the remainder of the H flus, non-typable or typable non-B H flus, certainly cause quite a number of respiratory infections. And if it's not H flu and it's not strep pneumo causing any otitis media, then you've got a third runner-up, and that's Moraxella. We also have a couple other bacteria gram negatives we need to think about, especially on the mucosal surface. And if you are a party animal and you drink a lot and you unfortunately make some bad decisions about using protection, let's see, let's cut that. And there are, unfortunately, a couple other mucosal gram negatives we still need to think about. If you, unfortunately, don't practice safe sexual activity, then one big one that we need to worry about is Neisseria gonorrhea. Gonorrhea. And if you're in a dorm or in close quarters and you start getting a severe headache, then it is meningitis. Meningitis. So those are the two big Neisseria strains we need to think about. Uh, there is one last one. You have a 6-week-old baby, unvaccinated, and a parent or grandparent is also unvaccinated. They have a chronic cough, and now the baby starts turning blue. What do they have? Bordetella pertussis, another big one out in the world. All right, so these are generally what we call the mucosal gram negatives. Now, there's a whole bunch of other bacteria. Like, I sort of went through the gram positives pretty fast. But don't forget, I mean, there's plenty of other gram positive bacteria we need to think about in medicine, but not going to encounter them that often. If you have a mom or a mom who's pregnant and she's about to she's sort of like 30 some weeks along and starts getting a flu-like illness, and now the baby is uh, starting to have premature labor. What do you have to worry about? Listeria comes in there. That's a big gram-positive rod. If you have fried rice and suddenly you start having severe diarrhea, well, B. cereus is certainly out and about. Um, and speaking of bacillus, you work on a sheep farm and all of a sudden you start having severe chest pain, coughing up blood. You get an x-ray, there's a widened mediastinum from hemorrhagic mediastinitis. What do you have? Bacillus anthracis. Or you open up an envelope with a white powder on it. That would be another concern. So lots and lots of, unvaccinated, severe sore throat, grayish plaques, Corynebacteria has, once in a while come up. But again, these are very rare instances, and we won't necessarily go through all of those. All right, moving right along. We have a 12-year-old, or let's say even a 22-year-old, who has had for the last week to 2 weeks a cough and just feeling crummy, low-grade fevers. Uh, when you listen to their lungs, there's crackles bilaterally. What do they have? They have, let's pick a new fun color for these guys. How about rainbow for the atypicals? And what makes atypicals atypical, you ask? Good question. Remember how we talked about gram positives and gram negatives both having cell walls, and it's really the outer membrane distinguishing? Well, atypicals don't have a cell wall, or they have a cell wall and it doesn't seem to be that important. A lot of times they're intracellular, and even if you use anti-cell wall agents, they just don't seem to care about it. And those we tend to lump in with atypicals because they behave that way. So the most classic, of course, with that atypical pneumonia is mycoplasma. And if it's not mycoplasma pneumoniae, it's chlamydophila pneumoniae. But remember, if there's chlamydophila, there is also good old chlamydia. If you get misted in the grocery store and now you have a cough and maybe some hepatitis, you've got Legionella. If, on the other hand, you are a avid hiker or hunter and you're out in the woods of the Ozarks doing some hunting, getting some good shots in, and all of a sudden you start getting a high fever and shaking chills and a rash that's petechial and it's all over on your palms and soles and everywhere else, then you need to worry that you got rickettsia. And there's a whole bunch of rickettsias. There's rickettsia typhi, like here in LA, you can still get rickettsia just hiking in Griffith Park or something like that. But that's rickettsia typhi. It's endemic typhus. There's also epidemic typhus if you happen to be in a trench and get bitten by a bunch of body louse. Then there's epidemic typhus, like rickettsia prowazaki. And there's a whole bunch of others: Connery, Akari, Africae. So Orentia Tsutsumakushi, one of the favorite ones. All of those are kind of in the rickettsial family. All right, so we got our atypicals covered, and then what do we have? We have another group of bacteria. Let's let's select our own color, shall we? See, come on, where are you? Oh, here, I think we do this. Let's have a nice brown. Let's see, where's the brown? How do I get a brown here? There we go, that's brown enough. Yeah, that's right, we have our anaerobes. And how do we divide up anaerobes? Interestingly, we just divide them up with gram positives and gram negatives. And it's really their unique metabolism that's why they're anaerobic. In fact, most bacteria, most of the ones that we see here, are generally facultatively anaerobic, meaning they can grow in anaerobic environments. If they just prefer, or they grow better, or even just exist in oxygenated environments without dying. That's what we consider to be facultative anaerobes. There's a few exceptions to that. Some of the environmental ones actually do need oxygen to survive, but most will grow okay in an anaerobic environment. But it's these obligate anaerobes that we really mean. And there's two flavors of them. Certainly there's millions of different anaerobic bacteria out there. Certainly some other interesting ones. But in terms of gram positives, the big ones that we need to think about, let's say some poor kid, some baby is born, it's a home birth, and they've got whoever clips the cord uses kind of dirty instruments, and then the infant, a few days later is feeding poorly and is starting to arch back and is not doing so great. What do they have? They have Clostridium tetani. They have tetanus. IV drug users also susceptible to this infection, wound tetanus. And if, on the other hand, the little baby ate honey, or more likely than not now, because everybody knows not to feed a infant honey, just from the environment, construction going around, that kind of thing, and now they're floppy and maybe constipated. That is where botulinum comes in. You treat them with antibiotics, and then they have terrible diarrhea, although not infants. Infants, that's a unique case. Then difficile is another Clostridium we have to think about. And sort of a fan favorite is always gas gangrene caused by perfringens. But in actuality, probably most of you, if you've made it through adulthood, have suffered from a Clostridium perfringens infection without even really knowing it. If you've ever eaten something that was a little bit bad or off, or got served something, and you suddenly, about 4 to 6 hours later, start having bad vomiting, diarrhea, you probably got infected with preformed toxin from Clostridium perfringens. So its most usual case is food poisoning, with maybe a second one from custards, and that being Staph aureus. All right, so moving right along, there's plenty of other anaerobes, even gram-positive ones, and we call them the GPACs, or gram-positive anaerobic cocci, like peptostreptococci. There's a whole mess of those, but rarely pathogenic, so we tend not to worry about them too much. In terms of gram-negatives, there's, again, a huge ton of anaerobic gram-negatives, but the one that we worry about the most is B. frag and Bacteroides fragilis. Bacteroides actually make up, in most Western diets and that kind of thing, make up quite a big bulk of your stool bacteria. Remember, a huge portion of your stool is actually bacteria. You have trillions living in your gut, and of the gram-negatives, Bacteroides is the major component, and B. frag being an important player in that. There's also a whole bunch of others like Prevotella, Veillonella, but those tend not to be nearly quite as drug resistant. So we think of them as sort of like, when we're thinking about like above the diaphragm anaerobes, we're thinking about all those guys, and when we're thinking about below the diaphragm anaerobes, we're really thinking about B. frag, and that's the major player. So yes, tons of other ones, but B. frag is the one we really need to think about. All right. So moving right along, I think we need to do some scrolling here, or maybe some zooming, a little bit of zooming and a little scrolling. There's one other important class of bacteria that certainly becomes clinically relevant. Let's pick a new color. Let's go with blue. You've got a little kid, and grandma comes to help. She has a chronic cough, and now the kid has not gained weight for a month, has been having a lot of issues like swollen lymph nodes, maybe occasional cough. What do they have? Well, of course, we have our mycobacteria. And of those, the one that we're talking about is TB. And how do we divide up the mycobacteria? Easy. TB and not TB. So non-tuberculous mycobacteria encompass a whole mess of different interesting bacteria and lots of neat infections. Things like, Mycobacterium leprosum, of course, disease from antiquity. You can also get them from armadillos, of all things, from lab-released armadillo infections. So just be careful around those armadillos, Texans and Oklahomans. But we also have like lots of others, Mycobacterium avium. If you ever clean out a fish tank and you get a cellulitis on your arm and then start getting spots up your arm, well, that is Mycobacterium marinum. Canzaceae, Coloni, abscessus, just a whole ton of them. But really, the reality is, if you ever end up with one of those, call me, call somebody else. If you ever end up with, an anthrax infection, call me, look it up, how to treat it. That's not something that you probably need to keep in your head all day long, whether you're a doctor or a nurse practitioner or a med student or anything. All right. Much more important to just be able to make the diagnosis and then look up the information. All right, so this is it. Like, oh my gosh, given the trillions and trillions of different bacteria in the world, this is sort of the subset that you're going to be seeing that are clinically relevant in most of your day-to-day practice as a physician, especially if you're in a hospital. A lot of these will come up quite a bit. So, not crazy. All right. So, a few rules in this introduction before we get started on the bacteria. So, I had a mentor, Dr. Ross, was really just an amazing, brilliant guy. He had like hundreds of rules. I'm not that brilliant. I don't have that much to say, so I just have a few. One, this is YouTube. You're watching this on YouTube, right next to like cat videos and people doing all sorts of crazy stunts, hurting themselves for the enjoyment of others. So this is edutainment. You don't really know me. I don't really know you. So it is on you to verify all the information and make sure that that this is not your only source, and that you, of course, look at other things. There's lots of reputable things. LexiComp will always be good. The Sanford Guide, Johns Hopkins Guide, all of those are reasonable places to verify information. And remember that this is being recorded on Monday, October 6th, 2025. And the reality is we live in a changing world where bacteria are becoming more resistant, and information I give you today might not be relevant in the future because things have changed and bacteria are no longer susceptible the way they used to be. So edutainment, edutainment. Don't just trust but verify, right? Another famous, I could write that too. The next rule is we'll be looking at a lot of different things. I'll mention side effects. Everything you do, everything in medicine, there's toxicity to. You can't get away with anything without having side effects. Now, in many cases, with many antibiotics, the safety profiles are really excellent. The likelihood of side effects compared to the disease you're treating it's like a no-brainer to use. Vaccines fall under that, right? The toxicity of vaccines is not to say that a vaccine can't cause severe issue or injury. It's just by far and large, they prevent so much more disease than they cause. But the reality is that everything has side effects. So you always have to know that. Again, I'll review some of the big ones, but it is on you to look through that. And remember, the minute you start any treatment, whether it's an antibiotic or whether it's biologic or it's even something as simple as aspirin, that you're remembering that anything you do can have these side effects, and it is on you as a physician to remember that iatrogenic side effects and that kind of things can be part of the patient's clinical course, and to recognize them as they develop, and most importantly, just to remember that that's an important other thing. All right, the third important rule, and this one is for your medical license. Your medical license and your patients will thank you. Generally, right? I mean, we live in an era of antimicrobial resistance and needing to be cautious, but it is general, if you have a really sick septic patient, to err on the side of the slow and steady march towards antimicrobial resistance and selecting somewhat broader agents for the task at hand, than trying to hopefully select a patient who is resistant to the microbe itself. That makes sense. So err on broader when sicker and you don't know what you're treating. And number 4 is the exact opposite, because we live in that world where always remember antibiotic stewardship. If you can, always choose when you know what you're treating, and especially if you have the strain and you've cultured it. So culturing is another important aspect of medicine. When you know what you're treating, choose the narrowest agent you can for the shortest duration that is reasonable for what you're treating. So in direct conflict with number 3, you do want to be a good steward, because we are rapidly marching towards returning to a post-antibiotic era. And unfortunately, if as that arrives, you won't be able to offer much more than perhaps surgical interventions. All right, so antibiotic stewardship. And probably the most important rule, number 5, we'll underline it twice, is check your antibiogram. The antibiogram is available if you work in a hospital. Your microbiology lab should be able to provide you your antibiogram. If you are outpatient and you submit to like Quest or LabCorp or one of these commercial labs, anyone who's doing the culturing should be able to. They generally will put together their susceptibilities for various antibiotics and let you know what what a good choice is or what a good empiric choice is. And that will help guide you with that number 3 and number 4 issue. If your local Pseudomonas is highly resistant to fluoroquinolones, that would be a bad choice. Whereas somewhere else in the country might have places where cefepime is really the right answer all the time, or another place that's always resistant to cefepime, and you need to use a carbapenem. So the only way to know that is to check your local antibiogram and really know what it is that's happening in your community. Of course, we live in an interconnected world, and so community boundaries don't exist nearly as tightly as they do. But by far and large, what's circulating in the community matters and helping you guide your choices. So with all that in mind, let's actually start talking about antibiotics. And I'll break up the lectures into various series, but these rules apply to all of them. I will remind you to refer to these. Really, really important that you keep up to date with what's new in your community and what's going on in the world at the time. All right.